the webinar so it won't make noise.
Thank you, Dr. Liow, and we welcome your presentation this afternoon.
Thank you, Dana, and aloha, everyone. Good afternoon. Welcome to the Department of Psychiatry, Jepson Grand Rounds. It's my pleasure to be here, and thank you, Dana and Dr. Guerrero and the Department of Psychiatry for the opportunity to be part of your Grand Rounds. I will be talking today about the recent FDA-approved Aducanumab and other emerging treatments. And let me see if I can have any luck forwarding this slide. There we go. So everybody knows about the blind man and the elephant. There we go. And I wanted to start with this slide. Hopefully you can see that the importance of perspective. The person, obviously, everybody knows that, the person that's feeling the leg of the elephant thinks that it's a 3, and the person who is on the ear of the elephant, you ask them, what is an elephant like? It's a fan. And obviously, the person who's got the tail of the elephant says that, what you ask them, what's the elephant like? It's a row. So I wanted to start with this slide, and I'm going to also finish with this slide, and hopefully you would join me with figuring out why did I share this slide. So as Dana mentioned, I do have some grant funding from the various organizations listed here. If anybody else has any other funding opportunities, want funding, tell them to come and talk to me. So we're going to cover 4 things. First is we're going to cover the pathophysiology of Alzheimer's disease, and then I'm going to talk about Aducanumab, and then I'm going to also spend some time talking about other emerging treatments that we are and research that we're conducting right here in Hawaii, and then we're going to finish off with some conclusion and some conclusions. So. Everybody knows about the amyloid cascade hypothesis, talking about the pathophysiology of Alzheimer's. Amyloid cascade hypothesis has, for the last more than 20 years, driven the therapeutic developments. If you've been following how the treatments are being developed. So let's take a minute and talk about the amyloid cascade hypothesis here for a minute. We can really, it all starts with the APP, which is the amyloid precursor, which is then being formed into our bad boy, amyloid beta 42 monomer, and then in soluble form, and then eventually into the insoluble form, the oligomers, and then the fibers, and then the all too familiar senile plaque. So there's a process that goes on here, and to develop therapeutic options, we can tackle the amyloid cascade pathway in several ways. First, by decrease the production. We do that either by the beta or the secretase inhibitor, and we have certainly been investigating several of the products, including beta secretase, which is attacking the amyloid at the and gamma secretase at the transmembrane level to decrease the production of beta 42 amyloid. Other things like monoclonal antibodies, which is like Aducanumab, works by inhibiting the aggregation of soluble monomer into oligomers and the insoluble form. And other methods is to increase the clearance of those insoluble monomer, insoluble fibers that's been formed. So there's several pathways to get there. So then, what does Aducanumab, what is it and how does it work? Aducanumab is a humanized monoclonal antibody. It binds to both the soluble and the insoluble aggregated beta amyloid. And I'm going to share with you two of the phase 3 studies, which has led to the FDA approval, which the eMERGE studies and the ENGAGE studies. Both studies are 18-month randomized double-blind placebo-controlled phase 3. Both studies are very similar, I believe. ENGAGE also eMERGE is limited to North America. ENGAGE includes also countries in Europe, as well as Japan, Australia, and South Korea. Who did they test? They tested patients with early Alzheimer's, meaning early MMSE 24 to 30, and LCMCI patients. So what are the dosing regimen? They use low and high. They randomized into one low dose, one high dose, and one placebo. So the chance of placebo is 33%. And what is the endpoint? Endpoint is CDR, sum of boxes, which I'll explain in a minute. There are other secondary endpoints. These are the tests: ADAS-Cog, ADCS, ADL, NPI-10, which is neuropsychiatric inventory, which we do here at the Memory Center Alzheimer's Research Unit almost on a daily basis. So what kind of patients did eMERGE and ENGAGE tested? So the average age of the patients is around 70 years old. And also about 9% of them are Asian population, which are important in Hawaii. And about 50% of the patients are on other Alzheimer's medication, whether it's donepezil, Memantine. About 70% of the patients are carrier of at least one set of Apple E4 allele. As you know, E4 carries high risk. So when they say carrier, it can be a homozygote or heterozygote. So at least 70% of them. And again, the patients tested include MCI and mild Alzheimer's patient, MMSE 24 to 30. So what are the results? Did it work? So like I mentioned, the primary endpoint, they measured clinical dementia rating, sum of boxes. So what is clinical dementia rating sum of boxes? Sum of boxes is an 18-point scale measuring cognition, memory, orientation, judgment, problem solving, and function. So it is in the clinical studies, in the eMERGE studies, at the endpoint at end of 78 weeks, there seems to be a difference, improvement of 22% in the patients in high dose. The one in the blue are high dose, and the green is an improvement of 15%, the one on low dose. And even in some of the other scores like ADL, NPI, greater improvement, 87%. So what about other parameters that they measured? Well, this is one of the things that you need to be in the studies. We did not participate in the study because we did not have amyloid PET in Hawaii. But this is what actually led to the FDA accelerated approval, which is an important point to cover. Pay attention to the blue line, which are the patients on the high dose. There is a 64% reduction in the PET amyloid imaging from the baseline, and even at the low dose, there's a 41% reduction. However, it is not clear at this point whether reduction in amyloid is a suitable biomarker or surrogate biomarker for Alzheimer's. So what is the results? Here's the summary on the phase 3 studies on Aducanumab, on eMERGE and ENGAGE. On the high dose in the eMERGE studies, results in consistent reduction of clinical decline. We're talking about CDR, sum of boxes mostly. And the main thing is the effect on the amyloid PET, which is a surrogate biomarker. And also there are some changes in the CSF, which we won't get into at this point. However, ENGAGE did not meet its primary endpoint. Remember, there's two studies, EMERGE and ENGAGE. ENGAGE did not meet its primary endpoint. Now, why is there a discordance between the EMERGE and the ENGAGE result? We don't know. It's been extensively investigated. Possibly the dose and the unbalanced distribution of rapid progressors. Perhaps ENGAGE had people, enroll patients that progresses more rapidly. Also, perhaps, however, in the ENGAGE study, if we look specifically at the high dose group, which is the 10 milligrams per kilograms group, the results are actually quite similar to EMERGE. So just like any drugs, any therapeutics that we consider, we have to find out what are the side effects, what are the things that I have to talk to my patients about, what do I worry about when I give this compound. Well, I want to introduce you to a word called ARIA, which stands for amyloid-related imaging abnormalities. These are the things that, and we do monitor this at our Memory Disorder Center and Alzheimer's Research Unit. When we give monoclonal antibodies, we do monitor patients for edema. You can have ARIA E, which stands for ARIA edema, and ARIA H, which stands for hemorrhage. Edema appears as this hyperintense signal, and hemorrhage appears as this abnormal signals in the parietal lobe in this MRI sequence here. We don't know why ARIA happens. Possibly it may be because the monoclonal antibody increased the cerebral vascular permeability because of the consequence of antibody binding to the positive beta amyloid. So the next questions that you're probably wondering about is, well, the patients that had ARIA, were they symptomatic? What kind of symptoms do I need to watch out for? Well, the most common symptoms were headache, confusion, dizziness, and nausea. And luckily, most of the symptoms were mild, 67.7%. And most of them occurred in the patients on the high dose, which is a 10 milligrams per kilograms dose. And even then, 74% were asymptomatic. Only about 25% were symptomatic. The other thing to note about ARIA is that it is definitely dose related. So remember, I told you there's randomization of 3 arms. So there is the placebo, 3, 6, and 10 milligrams arm. So the 3 and the 6 milligrams, they're randomized according to their ApoE4 status. So most of the ARIA happens in the 10 milligrams per kilogram arm. So that's probably why the FDA indication noted that they should, the MRI is being done at 7 weeks, at the 7 infusion, and also after the 10 infusion, because that's only when the dose get escalated to a higher dose towards the end of the infusion cycle. Remember that this is a weekly, monthly infusion. So is ARIA edema reversible? ARIA changes. Well, thankfully, about 98% of the ARIA edema resolve on study. Even in the one that's severe, 69% resolve within 12 weeks, 83% resolve within 16 weeks. So in summary, what is the safety profile of aducanumab and what are some of the adverse effects? The safety profile of aducanumab is well characterized. ARIA E, ARIA or amyloid-related imaging abnormalities, edema is the most common adverse event. They are mostly mild or moderate, and thank goodness they are transient, they're reversible, and they are asymptomatic in majority of patients. When they become symptomatic, they're usually headache, dizziness, confusion, and usually they are mitigated with routine MRI monitoring and dosing management. That's why you have MRI at 7 infusion and a 10 infusion. So I'm going to talk to you about something else. How about a Greek philosopher, Aristotle? So in 300 BC, the Greek philosopher Aristotle thought that the Earth is the center of the universe. How on earth did he ever come up with that idea? Well, Aristotle thought that because at any point during the day, if you look at the sun, it almost seems like it's always the same distance away from where he's standing. So therefore, the Earth must be the center of the universe. Is that correct? Well, we know that. Thank you, Dr. Abramovitz. You shook your heads. Thank you for saying no, because absolutely not. And why did I say that? I say that because is it possible that people who are so invested in the amyloid cascade hypothesis thought that everything else has to revolve around the amyloid cascade theory? And I borrowed this nice diagram from Dr. Ricciarelli at the University of Milan, who put out a nice article in 2017 in Current Neuropharmacology, titled it The Amyloid Cascade Hypothesis in Alzheimer's. Is it time to change our mind? So how about synaptic loss? How about oxidative stress? How about neuronal death, neuronal connectivity? How about neuroinflammation, vascular changes? Is everything really revolving around amyloid? Can I just get you to kind of like think outside the box for a minute? So if amyloid is not the only thing in the world that could be driving this, well, what about tau? What about inflammation? What about vascular changes? Can I perhaps engage you to think about brain metabolism? Now, the one brain metabolism is highly interrelated, affecting all of this pathway. If there's one pathway that's interrelated, affects all of this pathway, it is brain metabolism. That could arise from resistance to the action of insulin-like growth factor. So what does it mean? Well, we know that when you look at the FD glucose PET scan of Alzheimer's patient, this is not an amyloid PET, this is an FD glucose PET, this is an Alzheimer's PET, this is a normal PET scan of the brain. The red areas are normal, good, robust glucose metabolism. And you look at Alzheimer's patient, they're kind of like dropping off. The glucose metabolism is not normal, especially in the parietal and the temporal area. So is there a connection between brain metabolism and Alzheimer's? Well, certainly the company T3D thinks so, because they have came up with a product and doing a study that we're involved in called the Pioneer Study. They are so confident that it's going to work. They actually call themselves T3D. And as you guessed it, T3D stands for type 3 diabetes. My goodness, they're so confident this is going to work. I wonder if it doesn't work, what are they going to do with the company, you know? So it is based, T3D's tenet says that it is Alzheimer's is based on abnormal glucose metabolism and abnormal lipid metabolism. Both are created by insulin-like growth factor resistance. So really, what is the link between glucose metabolism and Alzheimer's? Well, we know that diabetics have twofold increased risk of getting Alzheimer's. 70% of diabetics ultimately develop Alzheimer's if they live long enough. And obviously, who knows, if they all live to 150 years old, maybe 100%. And we know that 37% of Alzheimer's patients are diabetic versus only about 9% of the general population. And there are many similarities between the Alzheimer's and the type 2 diabetes patient. The common theme is insulin resistance. This includes cognitive decline, neurodegeneration, amyloid aggregation, and inflammation. Remember, I told you that we wonder whether amyloid is a suitable biomarker surrogate for Alzheimer's disease, because there are many conflicting studies. Some studies shows that, well, when amyloid is decreased, the cognitive really do better. Some studies didn't show that. Do you know one biomarker that is even more consistent than amyloid? That is actually brain glucose metabolism. We know that You cannot have Alzheimer's cognitive decline if you do not have decrease in brain glucose metabolism. So what are we investigating? What are we testing? It doesn't have a name yet. It's called T3D 959. It's a dual PPAR agonist. So what's PPAR agonist? PPAR stands for peroxisome proliferator activated receptor. The primary target is delta, secondary target is gamma. And both are master regulators of metabolic homeostasis. It regulates both glucose and lipid metabolism. It's the only drug in development for Alzheimer's that use PPAR delta as a primary target. And luckily, PPAR delta is found throughout the brain. It is oral, once a day dosing. And we have, let me see, about 4 patients on this trial right now that are doing quite well. And it has excellent safety profile. It penetrates the blood-brain barrier quite well. T3D Pioneer Study in Hawaii at the at our Memory Disorder Center, Alzheimer's Research Unit, is an NIH-funded study, phase 2 study. Who are we looking for? We're looking for mild to moderate Alzheimer's AD patients by the NIAA criteria, MMSE 14 to 26. If you have any patients, please call me. We love to talk to them. Okay, let's go to talk about something else. Well, what about inflammation? What about oxidative stress? What about vascular dysfunction? Well, if you ever seen stroke patients, if you ever seen them, you know that, or if you deal with patients in the clinic, you know that you already understand that atherosclerosis, inflammation, and hypertension all can lead to cerebral blood flow reduction. And all we can actually see them on the MRI as usually we call them fancy white matter small vessel disease, those white little stuff around the ventricles. And why did that happen? We don't know why it happens, but it's postulated that there could be a breakdown in the blood-brain barrier dysfunction, leading to the neurovascular unit breakdown, oxidative stress, leading to beta amyloid deposits, and ultimately to Alzheimer's disease. So I want to talk to you about another compound that we're investigating here in Hawaii. Doesn't have a name yet. It's called CY6463. What is CY6463? CY6463 is a positive allosteric modulator that amplify endogenous nitrous oxide signaling. And we know that nitrous oxide signaling is fundamental to regulating neuronal function, neuroinflammation, and cerebral blood flow. So by regulating nitrous oxide signaling, we're hoping to improve neuronal function, reduce neuroinflammation, and improve the vascular function. In the early translational study, which we did not involve in, they tested CY6463 in 24 subjects for 15 days, and then cross over for another 15 days. Patients that were on the investigational product, they assessed safety, PK, and the data were actually just presented last year summer. Patients that were on the investigational product showed improved cerebral blood flow measured by MRI ASL or arterial spin labeling. This is a program that we actually had to install in our MRI here to measure. It also improved brain metabolism as measured by MRI spectroscopy. And we also measure neuroinflammation on the serum and quantitative EEG, which I'll talk to you more about. So if you have a compound that affects oxidative stress, vascular pathology, what subvariant of Alzheimer's patient do you think would most benefit from it? Well, obviously, you said it. So you have Alzheimer's patient with a pure Alzheimer's, and then you have the vascular dementia. How about the overlapping group? which we call Alzheimer's dementia with vascular pathology. Now, this group of patients usually shows subcortical vascular disease, or what the neurologist would usually say, small vessel white matter disease, blah, 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 blah. They like to say that very quickly just to confuse you, you know. But this would perhaps be an ideal population to do that, because this group of patients has no approved therapy for vascular dementia, and perhaps it can improve CY6463, can improve cerebral blood flow, reduce neuroinflammation. So here we are conducting this study for patients with Alzheimer's dementia with vascular component, that is mixed Alzheimer's and vascular dementia patients. Who are we looking for? We're looking for people over 65 years old, MMSE 20 to 26, must have 2 or more cardiovascular risk factors, any 2. Pick 2, any one that you want, hypertension, diabetes, cholesterol, or BMI over 25, you know. And MRI must show subcortical small vessel vascular changes. Give me a call. We want to talk to you. All right. We're making good progress here. I want to find out if anybody has ever heard of the Bridge of Ramallah, not the Bridge of Biogen. I'm just kidding. No, the Bridge of Ramallah. Anybody has ever heard of it? Well, if you've never heard of it, it's actually a famous bridge in World War II. What happens during World War II is when the American and the Allied forces try to fight the German forces, there was a stronghold in Eastern Germany that the Allied forces could never really conquer, because you know why? Because there was always a constant supply of armies, constant supplies of tanks going over the bridge, and the Allied forces were just frustrated with how much we always couldn't take a hold. So somebody came up with a bright idea. If you've ever been in the military, to take out a stronghold, what do? You destroy the bridge. Yeah, that's right. That's exactly what they did. The Allied forces destroyed the Bridge of Ramallah, and within 2 weeks, they took over Ramallah. Hallelujah. So why am I telling you the story? I'm not a historian. Why am I telling you this story? I'm telling you this story because back in 2017, somebody presented this data about, they said, why is so many of the drugs not working for Alzheimer's disease, especially the beta, the gamma secretes, and Remember, we talked about all this works at the initial production phase of the amyloid cascade. And they even speculated, look at this, Aducanumab, they said may fail. They even speculated that it's going to fail by Biogen, and everything else failed. We were involved in this Eli Lilly study. We were involved in this one. We were also involved in the missions, and Novartis CNP. We're involved in the mission study. So our center was involved in several of them. So why is all of this failing? So it's just like the Allied forces. How about taking up something more upstream? Are we tackling something that's two-way downstream? So somebody thought of, perhaps if we inhibit something that's common, how about taking out the bridge of Alzheimer's? So this actually expands beyond Alzheimer's. So let's expand our horizon a little bit beyond Alzheimer's. Let's look at, there's Parkinson's disease with alpha-synuclein, prion amyloid with ALS with the superoxide dismutase, Huntington's with Huntington inclusions. What is one common theme? They all have neurotoxic aggregating proteins. It's just like the Alzheimer's that clamp up the plaque. Is it possible that if we could interrupt the pathway by inhibiting the neurotoxic aggregating proteins, we not only may have be able to help Alzheimer's patients, but possibly help other neurodegenerative disease? I don't know. Let's take a look. Well, it happens that nature has already provided some clues to it. Guess what? Alpha-synuclein, Parkinson's, APP, Alzheimer's, prion, superoxide dismutase, ALS patients, tau, Huntington's. What do they have in common? Nature has provided us, they all have a common homology of neurotoxic aggregating proteins in the messenger RNA in the 5' untranslated region of the iron receptor binding. So is it possible that if we tackle this in the highly preserved consensus loop in the 5' untranslated region of neurotoxic aggregating proteins, we potentially could inhibit the aggregating proteins? Let's take a look. How do we do that? Well, we know that the neurotoxic aggregating proteins display some similar features from gene activation to protein synthesis, folding, misfolding, and the transcription. Although the transcription is regulated by copper and zinc, the translation of this protein is actually regulated by iron. So this may be a potential. There is a compound by the name of Posiphen made by NIH that we actually investigated last year that inhibits the translation of this neurotoxic aggregating proteins that's regulated by iron. How do they do that? So what does Posiphen do? Posiphen works by binding of the iron responsive element to the iron binding protein here. And by binding, it inhibits the it inhibits the translation of messenger RNA proteins, aggregating proteins. Did it work? Yes, and we presented this data just in June on Wednesday, a positive clinical outcome in 2 phase 2A study. Hawaii is involved in this study. As you can see, and I'm very proud to represent Hawaii in this presentation at the AAIC, Alzheimer's Association International Conference in Denver. What did we present? Well, we present the results of the Alzheimer's trial and the Parkinson's trial. In the Alzheimer's trial, we recruited 14 patients, early to moderate. Out of 14, 4 were from Hawaii. And the Parkinson's trial, same thing, we recruit early Parkinson's patients, 14, 6 were from Hawaii. This is a double-blind placebo control. What do we study? We studied basically biomarker study. We want to look for a reversal of the toxic cascade. So did it work? Well, mind you, it's only on 14 patients. What we did was we dosed 14 patients, 4 of them in Hawaii, 4 Alzheimer's and 6 Parkinson's patients in Hawaii with Posiphen. This is a once-a-day oral dosing. So at the end of the day 25 monitoring, the endpoint is when we measured. We measured the WAIS, Wechsler Adult Intelligence Skills. Dr. Gail Hosteller could probably tell you that this is actually a gold standard in some ways, because it doesn't matter how smart you are. It just, what really matters is how well you use your intelligence to measure. And in the Alzheimer's group, we see an improvement in the group that were dosed. And so did the Parkinson's group. There was improvement in the Wechsler Adult Intelligence Skill. And because of the involvement of the Parkinson's patient, we also measured UPDRS, which is Unified Parkinson's Skill Rating. And the Parkinson's patients seems to also do better that were dosed with Posiphen. And obviously, this is what's important, measuring the biomarkers, inflammation, neuroinflammation, and the interruption of the toxic cascade, inhibiting the aggregating proteins. The trial measured 4 inflammatory markers, C3, YKL40, STREM2, and GFAP, and they were all showed statistically significant reduction after even 25 days of treatment with Posifen. So we are very excited because we are going to be studying the phase 3, phase 2B and the phase 3 trial, hopefully either later this year or in 2022. And we look forward to working with our community for this trial. All righty. So everything that we talk about so far is about stopping the production, maybe inhibits the aggregation, but it doesn't. But what about the neurons that were degenerated? What about the neurons that has lost its neural function, or even lost its dendritic connection, or maybe even lost its synapses? Is it possible that is there anything that could potentially even repair, not just stop the damage? So let's dream a little bit. Let's talk a little bit about another therapy that we're investigating. So I want to talk to you about one therapy that we're investigating. It's called ATH-1017. So what is ATH-1017? ATH-1017 is made by the company Adira. It enhances HGF, hepatic growth factor receptor thyroxine kinase. HGF inhibits inflammatory cytokine productions by binding, and also prevent neuronal death and promotes repair. So we know that Alzheimer's brain, not only is there accumulation of the amyloid proteins, but we also know that the synapses died off, the neuronal death died off, the dendritics kind of disconnect. But is there some way we could reconnect, reestablish some of those neuronal function, reconnect some of this connectivity? Well, at least at the cellular level, ATH-17 proven in some ways to improve brain connectivity and repair of neuronal damage, neuronal function, memory formation, and even synaptogenesis. I'm just going to go back 2 slides here. So what here's the slide. So even patients that are dosed with the Adira ATH-1017, even within hours, we could see some effects of synaptogenesis, dendritic vaporization, which is dendritic regrowth, and angiogenesis and neurogenesis. I know this sounds very exciting, but these are all very preliminary findings that we have to be very forward thinking in some ways. How do they even measure some of this immediate effects? Well, even they measure this by using quantitative EEG and P300, which I will explain in a minute here. And so we know that we can actually measure neuronal connectivity and neural network function with EEG. We know that EEG, we measure EEG by the rhythm, the delta, the slow rhythm, and the gamma is the very, very fast activity. We know that in Alzheimer's patients, as they progress, as the connectivity is lost, the gamma activity decrease. That's one way. And then another way we can measure it is by P300, or positive 300 latency, is the evoked potential measured at the parietal lobe. We know that healthy patients, when you stimulate the evoked potentials, the P300 occurs approximately 300 microseconds after the stimulation. As the Alzheimer's patients progress in their loss of connectivity, this latency is delayed to 400, sometimes even 500 to 600. So we have actually been able to measure the neuronal network connectivity as the Alzheimer's progress. We know that the neuronal network connectivity gets less, get damaged, so does the gamma power, which is the very fast activity on the EEG, remember, gets diminished, and the P300 latency, positive 300 latency, gets longer. So isn't it exciting? We actually have a tool to measure neuronal connectivity. So Adira 1017 is also another NIH-funded study that we're doing here in Hawaii. It's a phase 2A study. It goes on for 6 months, patient. I believe the placebo rate is 1 in 3, if I'm not mistaken. After 6 months, we will guarantee medication where we have 6 months open label. We'll guarantee our patients. Who are we looking for? We're looking for patients with, this is actually exciting to me because most of the studies are done on MCI, even preclinical or early Alzheimer's. This study will actually take patients with moderate Alzheimer's because we think that even if there's disconnection, even if there's neuronal damage, we can try to reestablish. We can try to establish synaptogenesis. So we can take patients all the way down to MMSE 14 to 24. So, and again, NIH-funded study. Please come and talk to me. All right. How are we doing on time? Let's see. We're doing good. On the conclusion, although I'm very, very excited that FDA provided accelerated approval of Aducanumab for MCI and mild Alzheimer's disease. It's exciting, I have to admit. In the last 20 years, those of us who've been around, who's been using donepezil for years and years and years and seeing disappointing results, their symptomatic treatment. This is the first potential disease-modifying treatment. It's exciting, but we must not lose sight of the fact that, number one, we do not yet know for sure whether amyloid reduction on the PET scan on the Emerge and Engage study really constitute suitable surrogate for clinical benefit. Number two, although the ARIA is mild, reversible, occurs only in high dose, the real world safety data is not known. As you know, that clinical trials are different from real world, so we don't really know yet. And obviously, there's a huge impact cost on the healthcare. Expenditure is unknown. Aducanumab on average will cost $56,000 per year, monthly IV infusion. Our medical students did do a poll, and here at the memory center, calling out our Alzheimer's patient, we know that majority of Hawaii Alzheimer's caregivers are not ready for this treatment. What is the conclusion? What do I think? Well, it is really not about what I think. It is not even about FDA. It's even not about what I think about FDA, although I may disagree with FDA approval. It's not even about FDA approval. I would like to tell you a story about my friend here called Paul. So about 3 years ago, I got a call from a nurse practitioner at Kalihi Palama Clinic. Many of you know that Kalihi Palama are our heroes in town. They take care of people that nobody else wants to take care of. This nurse practitioner said that, Dr. Liow, I have a patient here, Paul. He's an immigrant from Poland. Obviously, he doesn't have any health insurance. He's been to different hospitals, in and out, probably every 3 months for seizures, and no neurologist in anywhere is willing to take him. Well, I mean, because he just doesn't have insurance. Will you be willing to take him? I said, well, of course, just in case you did not realize, me and my wife moved here 12 years ago from the mainland. That's the reason that we started this practice with one doctor and one employee, because we found out that there were a lot of patients without insurance that could not get care. I said, of course, that's the reason that we exist. Send him over. And since Paul has been coming to our clinic every 3 months, haven't had an admission to the hospital, we manage his seizure medication, and he actually came in here during one of the Christmas. And our staff was so happy that Paul even came in during Christmas. They loaded him up with goodies, with I don't know what they gave him, probably a lot of, and I hope he isn't diabetic, by the way, and loaded him up with all the goodies. And Paul was a blessing to us. This is Paul's caretaker. Paul has passed away 2 years ago, but why am I telling you about Paul? I'm telling you about Paul is because almost every month I see patients that get sent to my clinic that somehow fall through the crack, or they have been taken care of by somebody else that just decided that they did not want to take care of. They did not want to take the insurance anymore. And for the last 12 years, we have made it our mission to not turn anyone away. Whether you have Quest, whether you have insurance, you don't have insurance, that is our missions. And about 5 years ago, I have also noticed that one of our patients were flying back to the mainland every 2 weeks for clinical trials. And this is a kid. I wouldn't say that he's a kid. He's a 20-year-old, but his mom had to travel with him to the mainland every 2 weeks to do a clinical trials. And my wife convinced me that yeah, I can do clinical trials in Hawaii, despite the fact that most people tell me that you cannot do this in Hawaii. I was determined to do it just for the sake of this kid that was traveling every 2 weeks to the mainland. And needless to say that we, because of the support of the community, we have been very, very fortunate to be able to do what we do today, growing our organization of one employee, one doctor to over 50 employees. And this is never about me. This is never about FDA approval. This is about healthcare access, equity, and inclusion. And this is just my personal opinion. I believe that even though I may not agree with FDA, I'm not for Biogen. I'm not against them either, even though I may not even agree with Biogen. If FDA approve it, I believe that every eligible Hawaii patient should have access to approved therapies. And why is the reason? The reason is because the people that live in Lanikai or Hawaii Kai, if they don't have access to it, they can always fly to Los Angeles to get them. They can always fly to Mayo Clinic to get them. But people like Paul and anybody else will never be able to do that. So I'm advocating for healthcare access, equity, and inclusion. However, I also advocate for therapies as such to be provided only at a center that's equipped with trained specialists and staff to ensure that only the right patients receive therapy with MRI, CSF eligibility, and has the capacity to monitor the safety and the clinical outcomes of the patient. I am all about collecting data. We have volunteered ourselves to help Biogen, to work with Biogen to collect the phase 4 clinical and safety data of Hawaii patients, because Hawaii always get left out in all of these clinical trials. And I want to make sure that our Hawaii patients do not get left out. And if they're worried about healthcare costs, $56,000 a day, well, send them to me, because Hawaii patients need to have access and a choice to be referred to specialized memory center with access to other potential disease-modifying therapies, and I've shown you quite a few, and I can give them to our patients for free. So here it is, the importance of perspective. I hope that you walk away with this knowing that you could be excited about Aducanumab, but know that it may not be everything. The whole world doesn't revolve around Aducanumab, doesn't revolve around amyloid cascade hypothesis. What about tau? What about glucose metabolism? What about inflammation? What about oxidative stress? What about vascular changes? It is possible that to move forward, to move the needle on finding a cure for Alzheimer's disease, we may need to incorporate perhaps some of these treatments, perhaps Aducanumab with T3D, perhaps Aducanumab with CYP 6463. We need to mix these treatments up. So again, to recap, we would like to offer our patients in Hawaii the options to have a choice, an access, inclusion, and equity in healthcare. We can provide all of these clinical trials are provided free of charge, 0 cents to anyone, to our Hawaii patients. If you have MCI, mild to moderate, we can do T3D, Adulhelm, both are NIH funded. For preclinical to MCI patients, you can have, we did not talk about this study. This study will need a spinal tap for amyloid because it's preclinical. We need to know that you really do have Alzheimer's before we put you on a drug. Again, all three, both of T3D is oral, Novo Nordisk is oral, Adulhelm is a sub-Q injection. If you have vascular dementia, Alzheimer's disease with vascular dementia, we can offer you cyclophosphamide 64, 63. Even if your patient is agitated, we do have 2 other clinical trials for you with Avenir and Exome Accord studies. So I'm very, I think we're very fortunate. We have a wonderful and amazing team that can help our patients here in Hawaii. I would like to finish off by acknowledging our team and dedicating the presentation to patients like Paul here, who passed away 2 years ago. This is his wonderful caregiver who comes to the clinic with him every visit, and their precious family, whom we get to humbly serve and learn from every day. I'd like to acknowledge our faculty that has been working with us in the Memory Disorder Center and Alzheimer's Research Unit. And I'm very happy to take any questions. Thank you so much for your time and listening to me.
Thank you, Dr. Liow. Yes, our audience, you feel free to unmute yourself and ask your questions or type a question in the chat.
So we do have a questions. First on the chat, ask what if the aggregates are protective, trying to sequester some sort of toxin, but once they accumulate too much, then the aggregate themselves become neurotoxic. I think that's a good question. Whoever asked that. Oh, Dr. Abramovich, thank you for asking that. I'm not a basic scientist. Perhaps Dr. Abramovich, would you like to elaborate and perhaps somebody else on the audience might be able to answer?
I don't have any evidence for that. It was just something that popped into my mind when you were talking about, breaking down the bridge. Because I always wondered, I mean, we have all these different disorders with the different aggregates, and the common thing is the aggregates. Maybe they're serving some sort of purpose, almost like a pearl and an oyster, like trying to sequester some sort of toxin. But then when it accumulates too much, then it's toxic, obviously, to the neuron as a whole. But it was just a hypothesis. I was just like, but it looks like that drug's working, so that probably wouldn't be the case. You probably wouldn't be getting positive results if that were the case.
Yeah, good question. Thank you. Thank you. And I certainly open to the hypothesis. I think there are a lot of smart people working on those questions.
Yeah.
I'm going to leave it up to all the smart people to figure that out. And maybe Dr. Abramovich, you could figure it out someday too.
But it's so nice to see all these looking at dementia from all these different angles. I mean, we've been so amyloid central for so long, and that's why I was laughing when you brought up the Earth as the center of the universe, or the center of the solar system, because I knew exactly what you were going to say. It's amyloid hypothesis, and it's so true. So I can't believe you did all this in 12 years. It's amazing.
Actually, I didn't do any of it. My wife did it, so all credit to her and our team. We really do have an amazing team here with Dr. Chang, Dr. Vimala, Dr. Virag is another wonderful neurologist, Dr. Paul Smith, Dr. Ken Yamamoto, Dr. Srihasha, and all the wonderful people, Dr. Ricardo Burgess, who's been doing our LP. We do LP on almost a weekly basis for a lot of our studies because we have 6 Alzheimer's studies going on. So we do this LP amyloid almost on a weekly basis. Thank you for your encouragement.
Hi, Dr. Liow. I've got another question. My name is Morgan. I'm a second-year psychiatry resident. I also very much appreciate your holistic perspective to Alzheimer's and other dementias. I was curious. I've done a rotation at a functional medicine clinic, and they cited a book called The End of Alzheimer's. And in that book, they talk a lot about, you know, treating underlying vitamin deficiencies and, you know, any molds or anything that are present. And I'm just curious your perspective on that type of functional medicine approach for Alzheimer's and other dementias.
Thank you, Morgan, for asking. Are you kind of moving towards more of like lifestyle changes and kind of complementary alternative medicine? Is that?
Yeah, complementary alternative, and it seemed like it was pretty effective, but I don't know any studies for it.
Yeah, I mean, there's no questions that there are the good studies on things like my diet and things like that, which we routinely provide. As a matter of fact, we recruited Dr. Paul Smith for lifestyle medicine and brain health. He's a board certified lifestyle medicine physician. He's a retired chief of occupational medicine at Kaiser that have joined us. So all of our Alzheimer's patients, obviously, I am not the expert in any way. I just tell them, you know, we are so lucky to have Dr. Paul Smith here, and I'm going to send you to go and see him, you know. And then Dr. Paul Smith will spend an hour just talking to them about, you know, activities, lifestyle changes, the cardio activities, different kinds of physical activities, the changing your diet, change the food that you buy, change the way that you cook, change the way that you eat. So those are not always very pleasant conversation for me. So I always try to defer that. I have a, let me see, what time is it? Oh, it is 1 o'clock. Otherwise, never mind. I just have a story to tell. So we'll tell it some other time. But
Okay,
thank you,
thank
Morgan.
Okay, well, thank you, Dr. Liow, and thank you for being respectful of everybody's time. We really appreciate you taking your time out of your busy schedule to do today's presentation. So if no one has any other questions for Dr. Liow, or if anybody wants any contact information, I can share that if that's okay. Everybody, I hope you have a great long weekend and stay safe. Thank you again, Dr. Liow.
My pleasure. Aloha.